So let us discuss today about the stroke. So what is stroke? So stroke is a focal neurological deficit. Focal neurological deficit which is irreversible. So how someone will present with stroke? So either they will present with a face weakness, or drooling, dropping of face, dropping of one side of face, then there will be arm weakness, speech disturbances, and that's where we know that is the time to call an ambulance. This we all know, okay? So if it is focal neurological deficit and irreversible, then we call it a stroke. So what is TIA? TIA is reversible and the MRI findings will be normal. MRI findings will be normal and it will be brief. Okay? So what they ask in the question is that what is the score that estimates the risk of stroke in suspected TIA. So that the score that estimates the risk is ABCD2 score. Okay? Now A for age more than 60, where we give a score of 1. B for BP more than 140/90, where we give a score of 1. C for clinical features. Only speech, we give a score of 1. Unilateral weakness, we give a score of 2. Okay? This is only speech disturbances without unilateral weakness. Then D, duration. 1 to 59 minutes, we give a score of 1. More than 60, we give a score of 2. Another T for diabetes, we give a score of 1. So what they can ask here is what scores are given as 2, unilateral weakness and duration more than 60. So they can ask this. So when to suspect the low risk, high, moderate risk and high risk. So if the total score is 0 to 3, then it is low. If it is 4 to 5, then it is moderate. If it is 6 to 7, then it is high. Okay? Now suppose someone is presenting with a focal neurological deficit. Okay? Focal neurological deficit which is irreversible. What is the next step that we will do? So the next step we do is a NCCT brain. Okay? So now they can ask in the question whether we can do an MRI. What will be the answer? The answer is yes, we can do a MRI. But then why are we not doing it? The thing is that we know that diffusion weighted MRI is most sensitive for stroke. Then why are we not doing it? Because MRI is not readily available. Unless and until it is a stroke center or somewhere where it is readily available, then only we can get MRI. So it is not readily available, so we have to do a NCCT brain. Whenever we see such patients who is having any weakness, weakness in arms or slurred speech or having drooping of face, we directly go for an NCCT brain. We do not do MRI because MRI is not readily available, even though DWI is most sensitive for stroke. Okay, so if they ask what is the next step, we have to do, we do a NCCT brain. But if they ask whether we can do an MRI, the answer is yes, we can do a MRI, and even DWI is the most sensitive for stroke. So this statement is correct. Okay, but if they ask the next step, then we have to answer NCCT brain. Okay, now, and why we are doing NCCT brain? Because we want to rule out hemorrhage. Okay, so because we want to rule out hemorrhage. So after that what we do, we have to see whether there is hemorrhage or not. Okay, so we see whether there is hemorrhage or there is no hemorrhage. Okay, so if there is hemorrhage, then we have to go for a conservative management. Okay, if there is no hemorrhage, then we have to see the window period. Okay, if the window period is less than 4.5 hours, then we go for IV thrombolysis. Okay, now okay, so if the window period is in between 4.5 to 6 hours, then what we do a CT angiography, along with we can do a CT perfusion. So why we are doing this? Because we want to know that whether there is any perfusion penumbra, right? Because what does that mean? Suppose, let's say this is a part of a brain. Okay, this is our brain, and suppose here is the thrombus. Okay, here is the thrombus. Yeah, so there is a ischemic stroke, it is a ischemic part. So what does CT perfusion helps us? In CT perfusion, first of all, in CT perfusion we will see how to identify it. In CT perfusion we will see the colorful image. Okay, colorful image. Then what does that do? From there we can see the CT volume. Okay, from that we can see the volume and the flow. Okay, we can see the volume and the flow. So sometimes what happens is that this is the ischemic area. Suppose this is the area. Okay, ischemic area. So what happens is, let's say this part, there is the volume is gone. Okay, so the volume is impaired, like no blood is there. Okay, but no blood is there, but the flow is still intact. Flow in these areas are still intact. The volume here is gone. The volume in this area, the volume in this area is gone. The volume in this area is gone. Okay, but the flow here is still intact. So to see this thing, we do a CT perfusion. or a CT angiography. So in that case, we want to preserve this area. This area we want to preserve. So this is called as the penumbra area. Okay. So if we see that there is a intracranial thrombus, this is the intracranial thrombus here. Okay, this is the intracranial thrombus here. So if we see a intracranial thrombus along with a penumbra, then we know that we can do a intra-arterial therapy, that is intra-arterial thrombectomy, mechanical thrombectomy. Okay, mechanical thrombectomy. We can go to there and we can do a thrombectomy. Okay, and this is, remember, this is intra-arterial. Okay, intra-arterial, whereas this was here, it was intravenous if it is less than 4.5 hours. Okay, and this is intra-arterial. Now if we do not see any penumbra, okay, if we do not see any penumbra, no penumbra, plus minus thrombus, then there is no point of doing intra-arterial therapy, because that means no penumbra means what? This area is also, now this area is also the blood supply of this area has also been gone. So if the blood supply of this area is also gone, if it is also gone, like this area blood supply has also gone, and this area has also converted to like thrombus, ischemic area, this has also become an ischemic area, then there is no point in thrombolizing, in doing intra-arterial thrombolysis, right? Because this has already gone. So we are not able to save this area. Only we can save by doing intra-arterial thrombolysis is if there is blood flow. If this area has still blood flow, then only we can do an intra-arterial thrombolysis and preserve it. So that is where intra-arterial thrombolysis is useful, if there is a penumbra region. But if there is no penumbra region, this area is called the penumbra region. If there is no penumbra region, that means there is the flow is also not intact, the flow has also gone, so this also area has also become an ischemic area. So there is so what's the point of doing intra-arterial thrombolysis? So that is the concept here. Okay, so intra-arterial therapy is not useful. This is the approach of stroke. Now what are the contraindication of thrombolysis? So one is if there is a very high BP, that is 185 by 110. Another is if there is any bleeding diastasis, if there is any recent head injury or intracranial hemorrhage, and or if there is any major surgery in preceding 2 weeks, GI bleed in 3 weeks, there is a recent MI, and the last point is if the ischemic zone means that if the infarct if the infarct is more than 1/3 of the MCA territory, because then there is a chance of hemorrhage. So all these are contraindication of thrombolysis. So if the BP is 185/110, if there is any bleeding diastasis, if there is any recent MI, if there is any recent head injury, if there is intracranial hemorrhage, of course this is self-explanatory only. If there is a major surgery preceding 2 weeks, if there is a GI bleed in 3 weeks, if the infarct is more than 1/3 of the MCA territory, because in that case there is a high risk of hemorrhage. So these are the contraindications of thrombolysis. So these are the points of approach to stroke and how to manage it. That's it for today. Hope you like it.